Good afternoon, everyone. Thank you for joining us for the DDU teaching for advanced critical care echocardiography today. We're going to talk about tamponade. I was going to talk about along that with pericardial disease, but very kindly, I think we've got a chance for Dr. Louise Cole, who's going to present a few cases. And so I thought we'd just focus on tamponade, some really great cases she's got, and then we'll deal with the constrictive and pericarditis, things like that at another time, if that's all right. So why don't we start off with the standard question for every single lecture that has ever been done on cardiac tamponade to begin with, which is which of these patients has cardiac tamponade? So Arnie, do you want to have a crack at this? Just which one do you think has tamponade? 1, 2, 3, or 4?
All 5.
Or 5.
Trick question.
Yes, I know. It's the standard trick question.
Sorry, I had to unmute myself there. Can you hear me now?
Yes, we can. Hi.
Okay, so I would be looking for some critical features, which would be really RV collapse.
Nice.
In systole. So I'm very suspicious about the picture 3.
Yep.
But I can go through the other ones. So it's an apical 4-chamber view in 1 that, I don't know, it kind of runs slowly here, but I just see a large pericardial effusion.
Yeah, nice, excellent.
With not much else. In picture 2, there's obviously right atrial collapse, which is rather unspecific and sort of it would depend on the duration during the cardiac cycle.
Yeah.
Whether it's sort of meaningful.
Yeah, there's also maybe left atrial collapse in there if it doesn't come through very well, but there's also says right and left atrial collapse in number 2.
Yeah. Obviously, the heart also seems to be bouncing around a little bit in the sac, which can make it more difficult. And
yeah,
you would need to see a little bit more. So then about 3, we've, I'm not sure whether you get systole and diastole here right, but I would be worried about that. And you could put an M mode through it and then correlate it nicely with your ECG. And view 4 is obviously also a parasternal long axis view. There is a pericardial effusion.
And how about if I told you that every single one of those echo images was taken on a patient who walked into our lab?
Well, it's a clinical diagnosis, so
so if you had to choose 1, 2, 3, 4, or 5, the whole thing is the silly question. The still silly part of it is to say that of course it is a clinical diagnosis, and so based on the echo image, you can't say whether someone's got tamponade or not, because it's a physiological diagnosis based on clinical examination backed up by echo. So I think on any exam question, if they ask you about the echo, if they ask you about how to diagnose tamponade or something, the first thing is clinical diagnosis backed up by echo. So yeah, nicely done. So for me, the biggest one that I've was taught before in terms of diagnosing someone with tamponade, we hear all the usual one in terms of them being, hypotensive and distended neck veins and shortness of breath, worse lying down flat. For me, the big one's always been the shortness of breath. So and that's worse when you lie down flat. So we will talk about all the diagnosis of it with all the things that you've just mentioned with the RV and RA and LA free wall collapse. And sometimes I've found it a little tricky about knowing when to drain them or not. And the big one for me is about whether to drain it or not has always been the shortness of breath. And even if you're not meeting the hypotension or the signs of shock, but if someone's short of breath and they've got a decent pericardial effusion with signs of tamponade on echo, which obviously we'll go through, that's when I'll be deciding to drain them if we can, and we'll talk about that as we go. So to confirm the diagnosis, we need to look at a few things. And for advanced echo, that will include some of the things that we're doing just an ordinary POCUS study. So ordinary focused echo, you look for an echo-free space, you'd measure that in end diastole. We'd look at free wall collapse of the right atrium, right ventricle, and left atrium. We'd have got to assess the IVC to make sure that it's not short and small and collapsed, because sometimes that means an underfilled heart. So if you can give them a bit of fluid. Sometimes that can help sort of splint open the cardiac chambers, if you like, to make sure the pressure inside the heart is greater than the pressure inside the pericardium. I don't think I've ever, I think that sometimes bought me time, but I don't think I've ever seen this kind of pseudo tamponade, I guess they call it, versus true tamponade if you've got an underfilled heart. I don't think I've ever seen someone who's had a pseudo tamponade who then you've given a bit of fluid to and you haven't had to drain the effusion. Normally it just buys you a bit of time, as I said. But the big thing as well for the advanced side of things is looking at the variation in the mitral and the tricuspid inflow and seeing great big variation. That helps sort of explain that septal wobble that you get in tamponade. And that's important to try and recognize from the advanced side of things. So we'll go through each in turn. So first of all, you've got to have fluid in the pericardium, obviously. You've got your visceral and your parietal pericardium. You've got to have fluid that's sitting in that pericardial space. When that fluid gets to a certain pressure, it is going to exceed the pressure that's sitting inside the cardiac chambers, particularly the right atrium, right ventricle, and left atrium. From the right ventricle side of things, when that impairs the filling of the right ventricle in early diastole or early systole for the right atrium, that is going to cause collapse of that free wall. So the pressure in the pericardium greater than the pressure inside the heart, so it squashes it down. That means you impair filling. And that means that if you impair filling to the right side of the heart, you're going to have a fixed and dilated right ventricle, a fixed and dilated IVC, excuse me. Okay, and that's why we look for that fixed dilated IVC. If it's small and collapsing, you're going to have a very underfilled circulation. The theory is you give them a bit of fluid. That might help prevent that pressure differential so that you will no longer get free wall collapse and impaired venous filling. As I say, that has never, in my experience, stopped someone who's then needed a drain at some stage. If we've done that, generally I've gone home and then I've got a call about 2 o'clock in the morning and I've had to come in and drain the effusion, and I wish I'd drained it when I saw the first that I'd given them some fluid. And obviously when you've got that impaired filling into the heart, that's where you're then going to get impaired filling into the right ventricle, for example, will then stop blood coming into the left ventricle, which means you've got a low cardiac output, low stroke volume, you've got your shocked state, and that's how you get your signs of tamponade. The size of the effusion does not give you the idea of tamponade. So that the examples that we had in that first page, I mean, number one, where I had that massive pericardial effusion, that was someone who had uremia or something who walked into our lab. If you've got a pericardial effusion that comes over time, you'll see that this sort of chronic increase in volume that comes up. You're not going to get the signs of tamponade until very late in the sort of the volume of pericardial fluid. And, we can drain up to 1 liter of fluid off some people, as opposed to someone who's got acute tamponade. And I think we went through a case of the guy with aortic dissection, right? Someone who had dissection, and literally you got someone who is on 40 of adrenaline and got no pulse and GCS of 3 with a dissection, and we took sort of 10 mils of blood out of their pericardium, and they sort of, sit bolt upright coming back from the dead, and this sort of wonderful, it feels like what's that movie, Pulp Fiction moment, that's just taking out 10 mils of blood out of this patient's pericardium because it happened so quickly. So this is a real deal. It's and when it happens, it's astonishing. So yes, the size of the effusion does not equal tamponade. You can still get tamponade even with a very small one if it happens acute. Etiology, probably don't need to explain to everyone. Obviously, there are multiple causes of pericardial effusion, infections, particularly viral, I guess, inflammation, SLE, any kind of connective tissue disorder, I guess, renal failure, the uremias or the dialysis can give you pericardial effusions. Malignancy, of course, if it's hemorrhagic, that's normally a pretty bad sign, obviously, if you're getting blood in the pericardium. Iatrogenic, of course, sticking in pacemakers, things like that. There's an incredible shot I've seen the other day about someone who put a pleural drain in back in the 90s, and the pleural drains ended up causing a pericardial effusion, which is pretty impressive. Traumatic from things like dissection or from car accidents. And of course, post-cardiac surgery, which can be really hard to pick up, and that's where transesophageal echo can be really useful, or the subcostal views. Off-axis imaging can be really useful in that, looking for the localized pericardial effusion. Please interrupt me if I'm going too fast or I miss something, please. Let's start with the differential diagnosis, though, because that's important that we're making sure that we're not saying someone's got a pericardial effusion when in fact they've actually got a pleural effusion or they've got a fat pad, and we don't miss pericardial effusions because we're not looking for it. So particularly if someone's in a shock state post-cardiac surgery, we've got to go looking for localized pericardial effusions. I'll show you a couple of examples. So, Swapnil, are you up for a question, or do you want me to smash the echo fellow here?
Only thing is I can't see the echo properly. It's very slow moving. Is it for just my network or?
Sorry, is it working? Ben, up in Cairns, are you seeing these okay? These images?
Yeah, I can see that fine.
Okay. Oh, Swapnil, you get to go out of it. I'm sorry, it's not working brilliantly. I think it might be.
No, I think it's my network. Yeah.
Are you in the hospital?
It's pretty slow to me too.
Yeah.
Sorry. It's a Sydney thing. It's better up in Cairns. Well, why don't we start? Maybe we could ask. We'll ask Anne-Marie, our echo fellow. So Anne-Marie, okay. So pericardial and pleural effusion. So I'm going to show you. What do you think about this picture?
So there's both. So it's pericardial along
Beautiful.
There's a circumferential pericardial effusion, which is anterior to the descending aorta, and there's also a left-sided pleural effusion posterior to the descending aorta.
Sorry, Sam, can't hear her.
Let me. Oh, I can't turn her up. Sorry, now I have to ask her to speak up.
There's both a pericardial effusion, which is circumferential, which is anterior to the descending aorta on the parasternal long axis view. There's also a left-sided pleural effusion posterior to the descending aorta.
Beautiful, and I'll try and bring up some writing here as well. So the pericardial effusion, we're going to see it anterior to the descending aorta. So I think that's sitting in there. Yep. So the descending aorta is there, and it's sort of sitting in front of it, as opposed to the pleural effusion that sits behind it. And usually you don't see this pericardial effusion overlap into the left atrium. That's not always the case, but it's sort of usually it doesn't overlap. Between the RV and the diaphragm in the subcostal view, you can see, you'll be able to see it. Can be associated with chamber collapse. Obviously a pleural effusion, I'm sure there are case reports of it, but it doesn't normally cause impaired filling of the heart. A pericardial effusion is usually less than 4 centimeters, and we can see that it's probably greater than 4 centimeters in the pleural effusion back here. And also with the pericardial effusion, can you see that heart sort of maybe bobbing around a little bit? As opposed to the pleural effusion, which is posterior to the descending aorta. It can overlap and go over here to overlap with the left atrium. We don't usually see it between the right ventricle and the diaphragm in the subcostal view. You normally don't get signs of tamponade with it. It can obviously be much, much greater than 4 centimeters, and the heart's usually fixed. So just the standard ways. The big one, though, I think, is using the first one, as Anne-Marie was saying, is it in front of or behind the descending aorta? Okay. How about this one? So here we're going to have this little echo-free space in front of the right ventricle free wall. And my question is going to be, is that tamponade or pericardial effusion or a fat pad?
Is that to me?
Yeah, go on.
I think it's a fat pad. I think.
Nice. Sorry, I admitted Lee at the same time as showing you the answer.
Oh, sorry.
so why do you think is it? Because you have an echo-free space anteriorly? It's, yeah.
Oh,
That's all right, Lee. Perfect timing. Yeah, so we got that echo-free space anteriorly, but it's not echo-free, right? It's got debris in it. And sometimes you can get debris in it, particularly if it's sort of inflammatory, you know, transudate kind of picture, an exudate kind of picture, or if it's got blood in it, it can be not completely echo-free. But can I persuade you that the echo-free parts sort of move with that RV-free wall? So, and that's where you get the idea that it's fat. It's often associated with people who have got a little bit of sort of truncal obesity or lots of diabetes or something like that. But the big part for me is that it moves sort of in concert with that right ventricle.
Also, if it's, if it's anterior, and not posterior, and it's like with those characteristics, it's likely to be a fat pad because small pericardial effusions tend to be posterior.
Nice, absolutely. And the right ventricle could be also known as the anterior ventricle. So absolutely, this is why it's anteriorly spaced. Nice. So we've got Lee. Okay, and here we've got an example of a loculated pericardial effusion. So this is something that we might see in particularly the cardiothoracic patients. I don't think this was, because I've never seen a cardiothoracic patient after surgery who you can get an apical 4-chamber like this. So I think it's for another reason. I'm sorry, I can't remember. But you can see this, the pericardial effusion sitting here behind the right atrium, squashing that right atrial free wall. So that would help. That would be preventing blood from entering into the right ventricle, which can give you the signs of shock. But you can just as equally get it behind the left atrium. And I think looking for transesophageal echo early doors in these patients can be useful. Or as I was saying before, subcostal imaging I've found the best, or just an off-axis, getting an image any way you bloody can. But calling for someone who can do transesophageals is really useful. Okay, so that's how to diagnose it. So yeah, clinical diagnosis, try and figure out what the cause of it is, and then looking for the echo-free space of the pericardium, not a pleural effusion, not a fat pad. And here's how we can grade our severity. So we're measuring the largest echo-free space at end diastole, and that's really important when you're trying to compare them. Small, less than 10, medium 10 to 20, large, greater than 20, and or a swinging heart. Okay, so that's how we classify them.
Sam, does that correspond to CCs?
Does that correspond to, sorry, what was that?
Does that correspond to mils, like in the pericardium, like volume?
No, I mean, I don't know the answer to that. So you're saying if it's like in a pleural effusion, if you've got a, you take the size in millimeters and you times it by 20, you mean?
Oh, I don't know if there's a formula, but I think, I don't know, I vaguely remember something about, if it's small, it's less than 200 mils. If it's large, it's less than 500 mils or something like that.
Oh, and that's definitely how it would be. That makes sense from a point of view when I've drained them. If they're large, then you've got a whole bunch of stuff. Oh, Louise has got the answer. Here we go. So if it's small, so less than 10 millimeters, it's 50 to 100 mils. If it's medium, 1 to 2 centimeters, it's 100 to 500 mils. And if it's large, it's greater than 500 mils.
Okay, thank you.
And that's according to the Mayo. Pretty good.
Thank you.
Okay, and here's the bit I always forget. So I always remember that the right ventricle collapses in diastole and the right atrium in systole. If you can try and remember better than me, it's the right atrium is early systole, and I think that's as long as you don't have rip-roaring tricuspid regurg. And right ventricle is early diastole, and that's because it's when you've got the lowest pressure. So these two diagrams are the things that I always wish I could remember. So it's obviously the point of lowest pressure in that chamber where you're going to get the most likely time of collapse. And so that's systole in the right atrium, which is obviously when the right atrium is about to fill, and it's diastole in the right ventricle, which is when that's filling. And it's typically early systole and early diastole, unless you've got rip-roaring tricuspid regurg for the right atrium. Okay? In terms of the specificity and sensitivity, they are not perfect for any of them, okay? But the likelihood ratio is what's important from me, I think, from a clinical point of view. So if you see right ventricle free wall collapse, that patient is much more likely to have tamponade on a clinical basis, based on the evidence. I'm sorry, there's meant to be a reference to this, and I'm sorry I've missed that out. So the right atrial collapse, sensitive, not specific. Right ventricle collapse, it's more specific rather than sensitive. IVC dilation is really important for sensitivity, and that's going to bring us on to that true versus pseudo tamponade. Okay?
Sam,
yes?
Is that RV collapse occurs before RA collapse?
No, not all the time. So I think it's going to depend partially on what's happening with your hemodynamic status and valve function. So you can just get RV collapse.
Because isn't that the traditional teaching on the CVP dress, we see square root sign, and that's because of the RV collapse.
Absolutely.
But A wave still remains kind
Yeah.
of persistent.
And I
So
think, again, that's going to be dependent on the filling status as well, which is why that bit at the bottom in terms of looking at the IVC is so important as well.
mhm.
I mean, I think I'm going to be nervous about draining pericardial effusions just looking at the CVP trace, I've got to be honest. You know, once you've got the echo in your hand, it's just so much bloody easier, obviously. But yeah, so I think you can get it so it's just the right ventricle. I've got to say, most of the time I've seen it with both, right? You know, if someone's got tamponade, it's, you know, we've got those clinical signs that back it up physiologically, that back up the echo. And I think you use all the same old saying's going to come across. You use all available tools in your arsenal. So you're going to use your 2D features. You're going to look at your right ventricle, right atrium, left atrium. You're going to use all the views you've got, and you're going to use Doppler to look at the flows across the tricuspid valve and the mitral valve. And using all of that together, mixed in with the clinical findings, that's how we can then make the assessment on whether this patient has tamponade or whether they're maybe at risk of it, and we need to drain that. It's all about deciding whether you drain someone's effusion or not, right? So all I'd say is that the likelihood, the big thing from this slide would be just the likelihood ratio just skyrockets when you start taking those echo signs together. Does that answer the question, Swapnil?
Yeah, absolutely. And if there is a RV collapse and RA collapse, but there's no IVC dilatation, you won't drain the effusion?
I would give them fluid to try and buy me time to go and get the kit. I think that's my take-home point. So I'll just show you what I mean by that. Can I come back to that just in a second? Can I?
Yeah, sure, sorry.
So this just gives you an example of the left atrial collapse that I don't see all that often, I'll be honest, but you can see it in particularly the parasternal and the apical and the subcostal and probably the parasternal short. You can probably see all of these features. It's not common, but you can see it. So here you can see it just at the back in there on both of those features. So look for the left atrial collapse, and that would again be during during systole, as in when the left atrium's filling at its lowest pressure.
Sam, do they still say, like, sorry if you mentioned this already, 1/3 of the cardiac cycle?
Yeah, they talk about that being the sensitive sign, isn't it? So if it's greater than 1/3 of the cardiac cycle, it's more sensitive for being tamponade. More specific, excuse me, thank you. More specific for being tamponade. I can't remember, I don't really use that clinically because I sort of find that, you know, you've got your clinical diagnosis, they're short of breath. If I've got any kind of collapse, I'll do it. Maybe I'll say it's great. If someone put that in the exam, that'd be magic. But if they put that in the exam, but they haven't said that it's a clinical diagnosis, it makes me nervous, right?
Yeah, fair. Yeah.
I think it's you know, this is a clinical exam, and the big thing for me would be you've got to be, you know, taking the clinical sign and looking for the free wall collapse. But absolutely, it makes sense, right? The longer that the free wall's squashed, the less likely you're going to be having good venous filling of that chamber. So here's, to be honest, I don't know, have I even got a, no, so this, let's talk about this one. So as you said, this is almost like hypovolemic, or they call it pseudo-tamponade, where if your IVC is not dilated, that means that the patient's underfilled, and therefore those chambers are more likely to collapse because they don't have blood in them, right? So it's more likely to happen if you've got a small or a medium pericardial fluid, a medium or small pericardial effusion, because they got low pressure. And in answer to your question, you said, does it stave off needing to drain it? Well, yeah, it's meant to. But as I said, in my experience, I've normally then had to come in 6 hours later and drain the effusion. I just wished I'd drained it at the beginning. So I don't know whether it's a hard and fast rule. I guess the idea is if you've got tamponade, you give them some fluid, you stop you enable better filling. Again, do you have any other questions about that, Swapnil? Does that make sense?
Yeah, absolutely. Thanks.
So yeah, just the bottom line is it's really important to check for the IVC to make sure it's dilated. Okay, from the advanced side of things, using Doppler, so making sure the angle of interrogation is appropriate, making sure your scale is right, and then this is about making sure that your sweep speed is then right. So you're assessing at least, say, 6 or 7 cardiac cycles because you want to see the respiratory cycle. And with the respiratory cycle, we know that it's basically because of the increased pressure in the pericardium, all of the pulmonary pressures will get reflected onto the heart and be exaggerated. So that means that when you inspire in the non-intubated patient, you will get increased filling of the left ventricle, which pushes over the septum. And then during expiration, it's preferential filling for the right ventricle. So here you'll see that during expiration, the flows go down in the right heart and they increase in the left heart. And then during inspiration, it's the other way. And so that's the movement of the interventricular septum. So it's being pushed over to the right during inspiration, and, pushed over to the left during inspiration and pushed over to the right during expiration. And that's showing this exaggerated respiratory effect, which is one of the other signs for tamponade, okay? Magic numbers, I think they vary on which one you read. So I normally have this one as 40% in my head. I stole this off the internet from somewhere. Again, I'm sorry, I should have put the reference in. I have 25% variation for the LV, 40% for the RV, but I think that's okay if you put 25% as for both. But basically, you're just getting significant variations of ventricular filling and ejection. Okay. So who wants to have a crack at this one? Louise, do you want to go this one? So which of the following is not an echo sign of tamponade? So reduced mitral E wave velocity greater than 25% with inspiration, IVC less than 1 centimeter in size, RV collapse in early diastole, reduced tricuspid E wave variation. Nice, beautiful. So we're going to see those mitral E waves are going to change by more than 25%. You're going to have right ventricle collapse in early diastole, RA collapse in early systole, and obviously pseudo-tamponade is the one where you don't have a big fixed IVC. Okay, quick case, and I'll hand over to Louise for awesome cases. So this is a 79-year-old female. We had a MET call shortly after this patient had had a pacemaker insertion done. The procedure was abandoned because it was difficult, and a MET calls happened, and as that happened, they called for the focus study very quickly, and here you can see this large pericardial effusion with a swinging heart going in and out of it. And this is what Arnie was saying right at the beginning, is that M-mode can be really useful for trying to pick up when you're going to start to see the free wall collapse. And so you can see the RV free wall collapse just ticking through. And here you can see it, the RV free wall collapse, early diastole, the RV free wall collapse happening. So just in line here with where diastole is, so the end of the T wave. It's a big effusion, so that is number 1, so it's 3.4. So it's a large pericardial effusion, RV free wall collapse, a patient short of breath and hypotensive. Do not pass go, do not collect $200, pull out your pericardial drain. Whilst that's happening, we'll check out other features just to make sure. So here we can see our RV free wall collapse during early diastole, our A collapse during systole. If I could pause it and scroll through it and see it during systole. Beautiful shot there of the swinging heart going around during the cardiac cycle. Apical 4-chamber view, really nice view of the right atrial free wall collapse during systole. The RA collapse, you can just see it there during diastole, and it helps if you slow it down, of course. Making sure that we're seeing it and not taking it for a pleural effusion. So here we can see it in the subcostal view between the liver and the right ventricle. And are we dealing with pseudo-tamponade though? Can we give us some fluid and buy us some time? Well, no. I think we've got a big dilated IVC here. And I'm sorry, we don't have the Doppler. In terms of drainage, I'll just talk briefly about it, and maybe it's a sort of talk in itself. I use echo to guide how we do this procedure. So I use echo to help me figure out where to stick the probe. I don't use real-time guidance. I sort of use the echo probe to help me find my plane where I'm pointing away from the left ventricle, so pointing towards the right ventricle, and where I've then sort of maybe sometimes off axis so that I've got the biggest distance possible. So for example, the risk here, if I go subcostally, I see I've got to go through about 5 centimeters of liver. So I go, okay, well, you know, we do hepatic biopsies all the time, but still 5 centimeters is a long way to go. I've got a decent landing zone here of about 3 centimeters to get into before I hit the right ventricle. But if I am going to hit anything, it's better to hit the right ventricle than the left ventricle. People can die from hitting the left ventricle. And I've been reliably told by a cardiothoracic surgeon that you can't die from having a needle inside your right ventricle. I don't particularly want to test that theory out, but the idea is if you're going to hit a ventricle, hit the right one, not the left one. But one of the things that I've sort of started to do a lot more is look at doing an apical approach. And with the apical approach, I go off axis, so I don't use this approach. I actually end up trying to put it down the side of the right ventricle. So therefore, I don't actually, as long as I'm in the right angle, sort of off axis, I've got a huge landing zone. If I have like a 10 centimeter landing zone, it's only maybe 2 centimeters wide, but instead of aiming for that 2 centimeters wide bit to stick the needle in like that, I have it like that, and I come from an apical approach so that it's 2 centimeters wide, but 10 centimeters long. Does that make sense? So I'm doing a few more apical approaches, but you've got to be really careful. I'll show you an example of this. Once we've got the needle in the right space, we can do that standard old-fashioned thing where you take out a bit of pericardial effusion, put it on the drape, and it shouldn't clot. So that's one thing we can do. But next thing, I actually inject some of the pericardial effusion back in up the needle before I dilate. And I've then handed the echo probe to someone else so that they can take this picture. And this is where you should see bubbles in the pericardial space. And as long as you see bubbles going in the pericardial space, that tells you you're in the right spot. If you see bubbles in the right ventricle, you're in the wrong spot. If you don't see any bubbles at all, you're also in the wrong spot. So I've seen bubbles in a pericardial effusion, for example, and I've done subcostal approaches, in a pleural effusion rather than the pericardial if there are both. And that's, so using the bubbles to help you figure out where you've landed and just double checking your position.
Sam, in your experience, what's been the complication rate of like going the traditional sort of transverse approach, the first one you described, versus the more longitudinal approach you just described?
So I've had way more complications in terms of putting them in the subcostal approach. And the main complication I've got, and I don't know whether it's just the kit that we got in our hospital, is that I find I can, I have to go in a little bit further. I've had to fiddle around a lot more because it's that much further away with the needle, which obviously makes you nervous where you're getting up to the hilt of your needle stuck in someone's chest. I sort of feel a bit more anxious. I prefer it when I've only had to go in 2 or 3 centimeters. I find I'm a bit, so here we can see that the distance I've got to go is 5 centimeters. Here, the distance I've got to go in is like 1 or 2. I feel a bit more confident where I'm putting my needle when it's 1 or 2. But the main complication I've got isn't been with bleeding or anything. It's been getting it through the diaphragm. So I can dilate, particularly if you've got a young patient, going through the crura with the needle, and it's fine. Then dilating it up is fine. But when you pull out the needle, I've often find that the crura then come over, and then trying to put the actual pericardial drain across it, it's got stuck a few times. And so that's when I've had to abandon the procedure. So it's actually the diaphragm that's caused me the most problems. Having said that, I then called in cardiothoracic surgeons because I couldn't do it and I didn't have the stones to do it apically at that time. And they've just got like a dialysis catheter and just gone, don't worry about it, Sam, I've got this. I'm like, oh, no. And so maybe it just needs a bit of a stronger arm. But I've certainly, from when I've been doing it, I haven't had any problems with the apical approach, and it's got me out of trouble a few times. But I have alternatively seen I think I've seen one pretty bad complication potentially where a pericardial drain caused some damage to the left ventricle. But that's where it all comes down to where you're aiming your needle. You've got to aim your needle. Like here you'll see this is the apical drain I put in. Can you see the angle that I've got it at? It's not pointing as you would for the echo probe up towards the right shoulder. It's pointing up and anteriorly and across the chest, right? So it's going across the chest, up and across, so that when you look at the CT scan, you see it's skirting that right ventricle. It's not skirting the left ventricle. So it's really important.
Right.
It's not, you got to be happy with echo. You got to be happy with, I think, advanced techniques, and think about it pretty carefully, because whatever you do, don't hit the LV.
And have you, or has anyone here done that from a parasternal approach?
Yeah, I've never done it myself. I've seen it done. I've had a sensible cardiac guy say to me, "Don't ever do that." but that's just what I've heard from a cardiac surgeon. I don't know.
Okay, thanks.
I might hand over to Louise. So just quick summary. So if you're asked a question about tamponade, it's a physiological diagnosis backed up by echo. We're going to use 2D features of an echo-free space and free wall collapse, RA during late systole, RV during early diastole. We're going to look at variations in flow greater than 25%. So going to reduction in inspiration with the LA, expiration with the RV. And then we're going to use the echo to help guide our drainage. And when you're doing it, I don't do it real-time guidance, so I can focus on the needle, not the echo. All right. Any questions before we hand over to Louise? Cool.
Sorry, can I ask one quick question?
Yeah, sure. Hi.
I'm still sometimes a little bit confused about the inflow because everyone I speak to has quite different opinions about the utility of it, number one, and two as well, the numbers.
Yep, here.
I just quickly looked up the ASE document again, and they actually, for the tricuspid, they say greater than 60%.
Right.
Like,
So yeah,
the numbers are all over the place. I also read the 25 number. So it's, I sometimes.
Maybe I could also say that in my experience, the mitral and tricuspid inflow is never dramatically changed the way that I'm going to want how to manage that patient. Yeah. I think as long as you're saying there's significant variation maybe in the exam, I think it's important to mention it in the exam, but just call it significant. I think if you put 25% or you put 60, as I said, I have 40% in my mind from whatever book I read, which must have been sort of Catherine Otto's book. I think as long as you've got significant variation, that'll do for me. But I agree. I think it's it's a bit tricky.
Okay.
Louise got some great cases. I'll hand over to Louise.
Hello. Lee, are you behind your name?
You should be. Is he here?
Sorry, behind my day.
No, behind your name. All we can see is a name.
Yeah, the camera's above me, so you'll just see my.
Oh, okay. Is that what it is? All right.
Oh, hey, Lee.
So our first case is a 37-year-old man. Can everyone hear me? Because I've got a squeaky voice.
Yes, no, we can hear you fine.
Okay. So this gentleman is a known IVDU on heroin, and he had a recent admission with Streptococcus bacteremia and a suspected massive PE that was thought subsequently to be a septic PE. And then he discharges himself and he comes back to ED a week later with a 3-day story of shortness of breath and dull chest pain. And when he first presents to ED, he's afebrile, he's got mild hypotension, he gets lots of fluid, and they notice fresh track marks in his groin. So the echo was done on the same day that he was admitted. Oh, I need the...
This one?
Oh, yeah.
What do you need?
Oh, it's all right. Okay, so I'm starting off with the short axis view. Would anyone, Lee, would you like to comment?
Yeah, sure. So it's a short axis, predominantly the level of the paps. There's a little bit of the mitral valve that comes in during the cardiac cycle. The right ventricle looks large. There's septal flattening that appears to be accentuated more during systole.
Give me a bit more on that septal flattening. You're absolutely right. I think it does look like it's worse during systole. Anything else?
But it's still present during diastole. The right ventricle is enlarged.
What about the first cardiac cycle versus the third?
It looks worse during the first cardiac cycle, but that might have something to do with maybe the angle shifting a little bit during, respiratory variation.
Oh man, no, brilliant. Yeah, nice. So you're getting the change in that septal bounce with respiratory variation as well. So it's worse during inspiration.
And then there's I mean, there's some echogenic mass in the right ventricle, which might be a PAP muscle, but doesn't seem to be moving with the rest of the heart. And then we've also got a hypoechoic or a pericardial effusion that you can see all the way around the inferior surface. And then there's maybe a little bit over to the right side of the screen as well.
And if there wasn't a papillary muscle in the right ventricle, what else could it be?
Well, clot, vegetation.
Yeah. Before that?
Or what?
Before that? So the clot or the vegetation, absolutely, but it doesn't, I think it is sort of moving with that wall.
It's moving, it's moving in and out. It's more likely to be a moderator band.
Okay.
Nice, yeah, so
right.
normal feature, yeah, moderator band that's in there, I think.
Okay, moving on to the, remember his history though, that he had a massive PE on his previous hospital admission. Okay, so this is the 4-chamber view. Lee, tell us what you think about this one. I'll move on to other people later.
Cool. Look, I mean, it also looks like there's maybe increased trabeculation on the right. The right makes up the apex with the left ventricle, which again suggests that the right ventricle is enlarged. The right atrium's huge. It looks like the intraatrial septum's bowing into the left side. And again, there's at the apex and predominantly around the inferior surface of the heart, we can see a pericardial effusion.
Okay, any comment on that pericardial effusion?
Very echogenic.
You may anteriorly maybe. It doesn't look that echogenic posteriorly.
Okay.
Have a look. What about next door to that LV? Is it coming out okay? Can you see it all looks like speckled? It looks like I don't know, also like small sort of foam bubbles coming through it. Can you see all that?
Now that you've pointed it out.
Yeah, nice. So
okay, don't forget his history. All right. Moving on to the next one. So this is just a close-up. I think it was actually more to look at the right ventricular wall. Lee, what do you think?
As in the right ventricular free wall.
Yeah.
It still seems to be contracting all right. I wouldn't measure how thick it is from this angle.
Yeah, okay.
The atrioventricular valve seems to be opening and closing all right. And there seems to be less noticeable septal bowing at this view.
Yep.
I don't know.
Okay. Arnie, what do you think about this one? So this is his tricuspid Doppler. And the green tracing at the bottom is actually respiration. So when the sine wave goes up, it's inspiration, and when it comes down, it's expiration.
Okay, so I think the guidelines would suggest that you pick the first beat of inspiration and expiration after the start of it. So you could argue whether the 2 should be even 1 beat earlier, but regardless, there is minimal inflow, tricuspid inflow variation.
Well, it's actually a Doppler TDI.
Oh, sorry. This is not the inflow. Yeah, sorry. It's
no, unfortunately, no. Probably it meant that the inflow trace was pretty crap, so we've got the TDI instead.
Okay.
Can we say the same thing about TDI that we say about inflow?
I wouldn't think so. I'm not familiar what the measurements are there, to be very honest with you.
Well, it should be more than 9 centimeters. So it's obviously not 9 centimeters. It's 6 centimeters. So that tells you that the RV contraction is probably mildly to moderately down. But I think this was supposed to show that there wasn't any respiratory variation.
Right.
Louise, would you say that that RV is apex forming, or was it just sort of the way it's been imaged?
Sorry, say that again, Benny.
In the previous images you had, is the RV apex? Is it an apex forming RV? So, like, is it? Yeah.
I think so.
Yeah.
Yeah. So at least it's at least equal, if not overriding.
Yeah. Sure.
Arnie, what about this then?
So that's a subcostal 4-chamber view. And there, as we may have had the suspicion earlier, the RV wall looks quite thickened. I would like to measure it and see whether it's greater than 5 millimeters.
It's actually 8 millimeters. Sorry, I didn't include that.
Yeah, yeah. So it certainly makes me, I mean, we have several components here now in this patient's disease with sort of the previous PEs, whether he has some long-standing problems there, even CTAP, and then the infectious acute course, how that may play into it. Whether there's some obstruction, whether that effusion is infective.
Yeah.
That goes through my mind.
Yeah. What about this then?
How old was he again?
37.
So I can see, so even going back the view, the morphology of the tricuspid valve, can you actually flick back again to the other view?
Just forward one, I think. Just, maybe just let's make it back and do this.
It's supposed to do it automatically. Quite programmed.
Yeah, I see. I hardly see the tricuspid valve moving here on my clip, so I'm not sure whether I would pick up all the vegetations, but it certainly seems thickened on some of the views that I get here.
No, it's actually normal at this stage.
Is it? Okay. All right, but anyway, there's significant tricuspid regurgitation, as you showed me in the next view.
Yeah.
And his IVC looks like it's bigger than probably 2.1 centimeters. And
yeah,
is there? Well, it's less than 50% respiratory variation if a sniff test was performed during that clip.
Yeah. So does this? So we've decided, in summary, then, that this 37-year-old has a pericardial effusion, which has exudative properties in that we see speckles, echogenic masses inside the pericardial effusion, and we would be worried about infection. Does he have tamponade?
How is it clinically?
So he's got, what did I say?
I forgot.
Afebrile, mildly hypotensive, but it looks like he might well have active infection at the same time.
Short of breath?
Not particularly.
I was just going to ask that.
It looks like his chronic pulmonary hypertension might be relatively protective as far as the pressure inside his ventricle and atrium are raised, so the tamponade's less likely to cause collapse.
If you look at the
Apical
chamber, you get the impression that the left atrium is collapsing. And like I agree, as like Lee said, if it's not if that's the lowest pressure chamber, then that's likely where you're going to see the first evidence of chambers compression.
How do I start again?
There would be a practical consideration here. I think you definitely want to tap him anyway, because you want to know, is this infective? Is this all pus? So can hardly see him going past without that happening. So
Exactly right.
you
Yep.
will see the effect on his blood pressure and what may be the effect of sepsis versus tamponade.
Yeah. So in fact, he was drained the next day. It wasn't thought that he had major signs of tamponade, but Lee, I take your point that high right-sided pressures would protect you against collapse, given his previous pulmonary hypertension.
He also had some, maybe it's just the image on my screen, but he had some speck in the IVC.
SEC, yes. He
Yeah.
did.
So yeah, sluggish flow, shock, that sort of thing.
Yeah.
Do you agree with that?
Yeah.
Yep. So in fact, we grew MRSA from his pericardial drain. He subsequently developed endocarditis involving the mitral valve and the left ventricular walls. He had multiple septic cerebral emboli and ended up with right-sided weakness. And he also had Staph aureus pneumonia. Anyway, we passed off the problem to Westmead a week and a half later. So in summary, he possibly, maybe not, had tamponade, but he definitely had an infected pericardial effusion. Does anyone want to ask any questions that I can't actually answer?
That's a good case.
We've got a few other people online.
So the next one, we got Lewis.
Lewis McLean
Lewis.
he loves cases.
Okay. Now, this is an interesting lady. She's 56 years old. She was a Syrian refugee with developmental delay and had been wheelchair bound for some years. She had a known hemangioma in her liver for several years. In fact, it had been diagnosed 6 years previously while she was still in Syria, and it had grown since then, and she developed an acute major bleed into her liver. So she ended up coming to us, and the information on the echo request was persistent tachycardia post failed embolization of a massive hepatic hemangioma. Oh. Right, Lewis, fall into it, man.
So the frame rate's not, oh no, it's sped up. So parasternal long axis, there is evidence of a pericardial effusion, which is circumferential and echo free, so could represent fresh blood or fluid. Sorry, it's very jerky. The RVOT looks like it's collapsing, but I can't really get a sense of at what point in the cardiac cycle.
Yeah, sorry about that. That's a problem with the program.
No, it's all right. It's okay.
I'll fix that later. So we'll
yeah, and otherwise, the contractility of the left ventricle looked like it is probably okay.
Yeah. Okay, so moving on to the short axis view.
So short axis at the level of the aortic valve, there is there's something that looks like it's compressing the right atrium there, coming in from the left. I don't really get a sense of what that is, but the right atrial wall is collapsing as well. Once again, I can't quite time that.
What about the RV wall?
Yeah, I'd say the RV wall looks like it's a bit hard to know whether it's coming in and out of plane, but the RV wall looks like it's collapsing as well.
Any comment on the aortic valve?
So I can't really see enough of it to comment. Sorry.
Okay.
It looks thickened. It looks thickened? Oh, yeah.
No, it looks normal.
Okay.
So here's a still shot of the short axis early in systole.
Okay, so early systolic collapse of the right atrium is evident there. Left atrium's not collapsed. There's a small pericardial effusion posterior to the left atrium. The aortic valve looks like it's well open there. So that's reassuring. And then the RVOT that's imaged there looks like it's open as well. So that would be an early sign of tamponade, if the clinical context fit.
Okay. So there's a measure. It's 2.4 centimetres, the width. So what size does that make the pericardial effusion?
So that's a large pericardial effusion, greater than 500 mils, according to the Mayo Clinic.
Yep.
And
good to know.
Yeah, and yeah, it looks like it's posterior. It looks like it's mostly posterior on this view.
Yeah. Okay, Benny, what do you think about that?
She may not hear.
Oh, Benny, have you gone?
No, can you hear me?
Yeah, we can hear you now.
We can hear, yeah.
Oh, okay. Sorry, it's a bit jumpy on my screen.
It's a jumpy heart.
Okay. I think there's RA collapse there. That's what I'm seeing. It looks actually like quite prolonged. It's most of the, definitely more than a third of the cardiac cycle, if that means anything. And it looks like there's some septal. Yes, sorry, the temporal resolution is really terrible on my screen, but I think there's some septal flattening. And the right ventricle looks a bit, I don't know actually.
It's like a Mexican wave, isn't it, from the atrium to the ventricle?
Yeah, and it's okay if you say so. I can't see that on my because it just jumps around.
Flattening with respiration.
And then there's a pericardial effusion, which I think in some images it looks like it is a little bit, like I can see a little bit behind the left atrium as well. So it might be circumferential, but I would like fan through and have a look at that.
Okay.
So yeah, sorry, I can't.
That'll do. So there's the still shot. So this is early systole again on the 4-chamber.
Okay. Yep. So there's RA. There's definitely RA collapse there, and some LA collapse and pericardial effusion around the both atria, I think.
Okay.
So probably circumferential. And this is an inflow through the tricuspid valve, pulse wave. And based on...
You'll have to trust me that the measurements are actually E wave.
Okay. And there's no, what do you call it? Which one's inspiration, which one's expiration?
No, we haven't got a trace, unfortunately. We've just got lots of cycles.
Okay. Okay. So
but the variation is the suggestive part, isn't it?
Yes.
So yeah, so there's yeah, well, there is significant variation, whatever percentage you like.
Nice.
So there's 0.58 and 0.26 I can see there, and a 0.31. So there's significant variation. I would like correlate at least at the bedside while doing the scan whether it's inspiration or expiration, just to make sure.
Yeah.
Yeah, so that it signifies significant ventricular interdependence, so that supports tamponade diagnosis, echo diagnosis. Do you want me to keep going?
Yeah, you're on a roll.
Sorry, I can't. The temporal resolution is a bit bad on this, but from what I can see, again, you've got you've got some RV collapse here, and I'm thinking it's diastolic. Is that right?
It's very hard to tell when I can't slow it down.
Just trying to, because the marker literally just jumps around the cardiac cycle on my screen.
Yeah.
So I'm going to just presume it's diastolic. And then if you put an M mode through that might help with the temporal resolution a little bit while you're doing the scan.
There's your M mode.
Beautiful. So that looks like diastolic RV collapse, and then there you see the pericardial effusion anterior to that as well. So again, that supports the diagnosis of tamponade.
Can you please go back to one image before, Louis, please? The subcostal. Yeah, that one. Do you think that the liver has got some different structure there in the, and is it like that hemangioma compressing the RA?
I have no idea. Sorry, that wasn't there at the time.
I agree. It looks heterogeneous, doesn't it? It doesn't look like this kind of normal, sort of almost homogeneous appearance, does it?
Yeah.
I was wondering exactly the same thing.
Ought to be in the subcostal anyway.
Because even on the parasternal short axis, there was something which is compressing on the RA from outside, and it looks like in a subcostal view, that's what the liver mass is compressing on the RA.
But I guess the big thing, because I have similar thoughts, but the big thing is then it's a great example of how Doppler can be useful trying and differentiate it. I think if you've got something compressing the RA, you'd still expect, would you expect the respiratory variation to be as significant? I think the question is what do you do here? Do you drain this effusion or not? And I think based on the respiratory variation and the pericardial fluid presence, and the fact that even if you do have something compressing it, there's something else going on, I think you drain this effusion, right?
No, the question is, if you want to put in the context, this patient came after this hemangioma.
Oh, absolutely. I agree that there might be a structure there, but does it change what you're about to do next is my question.
No. The question is there a communication that's causing the tamponade? Why this patient initially...
excuse me, I see what you're saying.
The answer is we don't know, because we didn't see anything on echo. So
why this patient developed the pericardial effusion in the first place when he had only hemangioma, hepatic hemangioma?
I guess any kind of neoplasm can cause something, I guess.
It could be paraneoplastic.
Yeah, iatrogenic. They've had an angiographic procedure.
Yeah.
All right, yeah.
Angiographic procedure, you won't go near heart, I guess.
No, you'd hope not. But who knows what they did. In fact, this actually had a sad ending because her hemangioma was inoperable because of its large size, and the fact that she'd had 2 failed embolizations. We eventually, a week later, ended up palliating her, and we never drained the pericardial tamponade. Now I didn't get onto that one, but that's what her IVC looked like.
You'd like more cardiac cycles, wouldn't you? Again, it's got that heterogeneous appearance to the liver, right?
She's got a great big thrombus sitting in her IVC.
Yeah.
So maybe they did go a bit too far. Who knows?
Yeah, and the liver looks terrible.
Terrible. Yeah, lots of stuff.
Guys, I think that's probably time for today. Maybe we'll leave this case for another time, or I'll steal it for the DDU exam probably. Guys, I would just say thank you very much for everyone for joining, and we'll see you next week, okay? Unless there are any other questions.
Thanks, guys.
All right, thank you very much, everyone. Cheers.